I get a color flow image, look at it, make sure where my track is going to go through. I'm trying to avoid hitting the vessel, the big vessel that's right at the center of this lesion. And then you can avoid significant hematoma afterwards. Here's the elastography image, which shows that this is a very, very hard. It's blue, and the hard scale here is blue. Again, you have to look at your scale because sometimes it's reversed. Sometimes the red is the hard one, so you have to make sure what your scale setup is. But that tells me that this is a hard lesion. All the criteria suggest malignancy, so we need to sample this one. So here's the needle coming in. This is the lidocaine needle. You can see a lot of the dark stuff around it, which is basically showing us the fluids, the lidocaine that we're depositing. And you measure your distance, and you can actually see your needle going through here. So that's kind of the core biopsy going through. You did see it real time, right? So you can see that. Let's see if I can run it again here. Oh, not that one. Okay. Let's see if we can run it. You're going to see like the semi blue that can actually show you the needle going through, and that's sampling the whole area. Again, you measure your 2 cm, you measure, make sure that you're firing, if you're using a 2 cm or a 1 cm, that you're safe to fire, and then you fire. And then after that, you place, this is the same lesion right here. Here's a second pass, and you can actually see different areas. So we're sampling again superficial, mid, and deep. You get different parts of the lesion, and then you put your biopsy clip. It's a 1 cm lesion, so you can actually put your biopsy clip right in the center here, which is a good position. What I usually do is technical, and we'll probably discuss that after we finish, so that I don't run out of time here. Here's again the biopsy clip, which is localized nicely. But now the surgeons come back, it's invasive ductal carcinoma, they need to wire localize. This is an unpalpable lesion, it's a 1 cm lesion, and they need to do a wire lobe for this. So here's again my numbing medicine. So we put lidocaine right before the lesion. I would do still lidocaine for the wire, despite it's a very small, but the needle that comes with the wire is a little bit big and it's painful, so you put some lidocaine, the patient doesn't feel anything after the initial burning sensation. And here's more numbing medicine. You can see this dark stuff, all that is lidocaine being deposited along the track that you come through. And then you put your wire. The best position for the wire is to go through the center of the lesion, and you anchor your hook while you're coming back out of the lesion. And the tip here is you go through with the needle, and the wire is inside the needle all the way to the end of the lesion. And then you pull back, and the hook will anchor against the lesion. The problem is some people would actually sit at the center of the lesion and then try to push the wire through. These tumors are very, very hard, and a lot of times you cannot push the wire. And what does happen is you already pulled your needle out, and when you try to make sure that that wire is fixed in place, what happened is it didn't open up. That hook didn't open up. It comes back right away out of the tumor, and you lost your track and you lost your position. So again, another trick to do is just go through all the way with the needle and wire, and then pull the needle out, and the wire will hook against the backside of the lesion. It's in the fat. That hook is in the fat already, distal to the lesion. And when you pull back, it's going to anchor against that hard lesion. It's not going to go anywhere. That's how you fix it in place and make sure it's correct positioning. So here you can see this wire coming through all the way across. And here's the hook. I always give my surgeons, despite that they come down usually most of the time and look at it with me and make sure that where's that wire and how they can approach it. But here's the hook and here's the lesion. You can see it's anchored against the backside of the lesion. So they know exactly where it is, and he just goes and follows the wire till the end. He got his lumpectomy specimen. And then they will get, here's another image of it. And what I always do is real time, I will give them a cine view while I'm pulling on it and it doesn't move. So for whatever reason they do anything in the OR while they're cleaning their stuff, I got my proof that this is anchored and it's not going to move. So if they pull it, yank on it, or do something weird in the OR, it's not my error, it's their error. And here you can see I usually give them a clip mark where the clip is, where the wire is, and where the hook is. and you see that already with the lesion. I labeled all that stuff in case the surgeon is busy and cannot come down and discuss it with me. If he's finishing one case and he's going to start with the next one right away, at least he has the images, and if he has any question, he will pick up the phone and call. They will get the specimen radiograph for confirmation, and this is what we get. You got your lesion, you got your biopsy clip right at the center, and you got your wire right adjacent to it, going through exactly where we positioned it. Here's an interesting case that I'll kind of share with you. This was a very difficult, large-breasted lady. Small lesion showed up in a mammogram. Year before, there was nothing. So we definitely were concerned about it. 2 views looks concerning. Spot compression views definitely looks ugly, with even small speculation. So we looked at it with ultrasound. It's a 5-6 millimeter lesion, classic, hypoechoic, irregular, shadowing, all the criteria that you don't like to see in a lesion. 6 by 4 millimeter in size. So we decided we have to sample this. So we did. Here's a nice core going through the lesion. So it's a 1 cm biopsy because this is a 5 millimeter lesion. So I pick up my needle. 1 cm is good enough. So I'm sampling before and in the lesion, and then a little bit after the lesion. We did our passes, and this was very small. So when I deployed the clip, it migrated about 5 or 4 millimeters from the lesion, which is okay still. I mean, as long as we discuss that with the surgeon, they know where it is, it's fine. The pathology came back as fibrosis and no malignant cells. So the surgeon told me, you're really suspicious of this lesion. I said, yeah, this looks like malignancy. It wasn't there before, now it's there. We'll do another attempt, and we'll sample it again. So I came from the opposite side, did a second biopsy, didn't put a clip because the clip is already there. Came back the same exact thing. Fibrosis, scarring, no malignant cells. 3 cores through the small lesion, no malignant cells. So the surgeon said, you're still suspicious? And I says, yeah, that's for me still, that's 4. And you're going to have to do surgery on this one. So I'll wire lock it for you, you'll take it out, and we'll figure out what it is. So that's what we did. Here's the post biopsy. You can actually see the clip is right behind the lesion, right adjacent to it, a few millimeters from. And then a little bit of clip migration when we tried to localize this one. We found that the clip even migrated even further. Here is the wire rope for this patient, so you can see the wire rope right here. And this is what I say this is the needle that goes in, the wire is still within the needle, and then you advance your hook right at that level and you pull the needle out. So what I tried in this one is to position the hook right by the clip, and because it's migrated, so he can take it out as well as the specimen, and put the wire through the lesion itself, which we did right here. You can see you have to confirm it in 2 views. If anyone is doing wire locks, you have to get true lateral and CC projection. You have to confirm your position, and here exactly what the specimen radiograph shows. The hook is right at the tip where the clip is, and your lesion is right by the second bead where he took the specimen, and the whole lesion was out. And to my surprise, this was a radial scar. So it was actually correctly sampled 2 times. Well, it was just because it's so suspicious that it showed up like this. For whatever reason, it turned out to be a radial scar. Briefly, we'll go through lipo dissection. If you have a deep lesion, what you need to do is separate it from the chest wall. The same technique we use for superficial lesions. Put your lidocaine right underneath the lesion, put 4 or 5 ml, lift that lesion away from the chest wall. So when you put your needle, you're safe. You're not going to get into the chest wall, you're not going to get any pneumothorax as a complication. So again, that's very important. Here is such a lesion which is deep, right by the chest wall. So here's the lesion right here, and we started depositing a lot of lidocaine underneath it, separating it from the chest wall. And here's the sample going through it. And you can see the biopsy gun. So I'll show you this again. This is how it looks when you fire the first one. You get the divot. So if you see the line that comes in, that's the white line, that's the needle, and then the divot is it makes a dip, and the white line continue underneath. That is the divot. That's where the sample is. And then the next one you're going to see it will cut through that area of the lesion. You're going to see that line. It's double lines, one dense on the top and one very thin and very less white on the bottom. That's where the sample is getting in between those 2 lines. So we did 5 passes on this patient, and then we placed the clip. So other than, just briefly, I'll talk about lidocaine toxicity, so that you don't really be very generous with the lidocaine. Usually you don't need that. I've never had any lidocaine toxicity. I never exceeded more than 10 ml of lidocaine for any of the patients. But again, just be aware that there is lidocaine toxicity if you use quite a bit. Central nervous, cardiovascular systems are susceptible. Signs of toxicity: dizziness, disorientation, speech changes, hypertension, tachycardia, tachypnea, a lot of things, seizures, depressed cardiovascular status. Predisposing factors usually in the elderly. They have lean body weight, which is very small, not a lot of fats, liver, pulmonary, cardiovascular disease, and anxiety in pregnancy. And limiting factors are the presence of vasoconstrictors. Can we override this? My IT help? Just close this, maybe. Yeah, okay. So we're still working. No, I did it. I think I did it. We'll give a couple more minutes, hopefully not too much. The maximum dose that you can give with the lidocaine is, without any epinephrine in the syringe, 4.5 milligram per kilogram. The maximum dose is 300 milligrams. Your maximum, basically amount of volume is usually 30 ml. I rarely go beyond 10, so I don't think you need that. And the duration for it is going to be 30 to 60 minutes. Those procedures shouldn't take more than 20 minutes, and if it's so difficult, it's 30 minutes max, so you should be safe that way. If you use lidocaine with epinephrine, it's 7 milligram per kilogram, and the reason is the vasoconstriction allows you to give more lidocaine. It's slowly getting absorbed, therefore it's much safer at higher doses. And the maximum amount you can give is 40 ml or 40 cc, and it lasts much, much longer. I really need 2 hours to 6 hours for these procedures. So, usually we use lidocaine without epinephrine. Just a brief word that if you don't have needles which are echogenic like the one we have here, that you can actually see it, you can make your needle echogenic by yourself. Just, mark it with a scalpel, multiple times. That will make the surface irregular, and you'll be able to see the echogenic needle. So if you don't see, you have to see your needle. If you can't see your needle, you're not doing the patient a service, because basically you can be anywhere with that needle and getting to the chest and getting into the lung and causing pneumothorax. So this is a simple trick that you can use if your needles are not echogenic. If you have a deep lesion, you can use a more horizontal course, large gauge. I would encourage using coaxial system. It's much more comfortable. What I use is usually a 14 gauge and a coaxial, which goes through a 13 gauge. I go with one needle only one time, right before the lesion, and then I direct my needles once up, once middle, once down, within the same track, within the same coaxial system. Then get this one out, put the clip through it, get the biopsy gun out, put the clip through it, and be done. And another trick, what I usually do is my last biopsy sample, if I'm doing the third pass, and I'm happy with the 2 core samples, we put it in a fluid with a preservative, and your sample is good if it actually drops down at the bottom of the fluid. If it floats, that means that you probably got fat. You didn't get anything of the lesion. If it drops down, you got a good sample representative of a lesion, whatever it is, fibroadenoma or tumor. That will drop down. If that happens, at my third pass, I got 2 which are correct. At the third pass, I will advance my coaxial on the needle. It went already fired 2 cm distance where the coaxial is. So I will advance my coaxial to the middle of the lesion and pull the other one. So already I'm at the middle of the lesion, then I can deploy my clip right at that middle of the lesion. Let's switch gears, and finally we're going to talk about just the fluid drainages. If collection is small, attempt aspiration without putting a drain. Usually, if it's a cyst and symptomatic, just a needle is good enough. You'll aspirate all the fluid. Always good idea to send it for cytology, make sure that there's no malignant cells, because there are intracystic lesions and intracystic tumors. Most of the time you can see the lesion by ultrasound, but every once in a while you get malignant cells and these cysts which you don't see much around it. Here's a left-sided fluid collection, and if it's complex collection, usually the aspiration of these usually requires end hole catheters, which mean use multiple side holes, because if it's complex, meaning there is a lot of debris, there is maybe blood, hemorrhage, whatever, it will block your tip of the catheter, and you may stop aspirating in the middle. So what we do, we have these 6 gauge angio cat, which has an end hole and multiple side holes, about 4 or 5. You can see some of them here. One of them is on the side of this, right there. And there's like 2 here and 2 on the opposite side. so it will aspirate all the fluid quickly. We usually connect it to a vacuum bottle if it's a big fluid collection, and it just in a few seconds gets everything out. Here's an example in the left axilla, a big fluid collection, and here's the post procedure, so there's nothing left. If it's large or recurrent, you may want to put a drain in. Every once in a while you get one of these that are stubborn and comes back again a week later or 2 weeks later, so we put a pigtail drain. Here's another big fluid collection that we had to put a drain in. And here you can see how the drain comes in through the lesion, through the fluid collection, and then you do the pigtail. You pull the thread and you allow the pigtail to form, which you can actually see here. It's one loop and a second loop inside the fluid collection, and then you aspirate, you allow that to connect to a bag or a vacuum bottle or wherever, it will drain all that fluid out. This is this patient after the mastectomy, got the fluid collection. This is the treatment planning CT, just to show you that the fluid collection is gone and it never recurred back again, so it's time to pull that catheter out. Here you can see ends of the tip of the catheter and there's no fluid anymore. So then at that point in time you take it out. Sometimes you put the catheter out, they recur back again. That means it's again recurrent and it's a problem. Seroma is the most common post-mastectomy complication. Rare cases require capsulectomy. Sclerotherapy is a feasible treatment option. What we use for sclerotherapy, usually you put an 8 French catheter, and then we use a 3-way stop and a pump for suctioning or flushing. And I usually use ethyl alcohol, but you can use povidone, iodine, or doxycycline as well. We treat these patients weekly, and again, first week you treat it, you put the alcohol. So what we do is I usually put in the catheter first, put a little bit of lidocaine, maybe 5-6 ml of lidocaine in the cavity, because it's that alcohol is so burning. The good news is these patients usually are post mastectomy. Nerves are cut already, so they usually are asymptomatic, but the alcohol is very burning. If you're going to use alcohol, it's painful. So just for safety, I usually put few mLs, 5 to 6, maybe maximum 10 ml of lidocaine first, and then we put the 100% ethyl alcohol, leave it for about half an hour, and then come back again and aspirate all that stuff from the catheter out and allow it to collapse. The alcohol is irritant. It usually initiates fibrosis and scarring, and hopefully this cavity will collapse and closes. The first time it's like 150 to 100 ml that we got before we put the stuff in. We aspirated 200 ml. The next week it comes back, it's like 100 ml. The third week it's like 50 ml. The fourth week it's gone. So that's how we do it. 2 to 3 times usually is adequate and enough for that. So I'll conclude with, again, the same thing we started with. Pre-procedure consideration of patient comfort is very important. Target lesion position and correct device selection is very, very important for your interventional procedures. Again, positioning, very, very important. Adequate anesthesia so your patient is comfortable. We have to consider ourselves in the same position, and you want to make sure that that patient is comfortable, as if it's a family member. You want your family members not to feel any pain during such a procedure, and if it's in your hand, give it to them and make sure they are comfortable during the procedure. Needle visualization, make your own scratches if you need to, and again, the methods of aspiration and seroma we covered. And with that, we'll conclude with this nice picture, which I asked everybody yesterday where that is, and probably nobody knows about it, but this is from inside in a boat in Khalil Nama in Sharm el-Sheikh, the most beautiful place for sunrise or sunset that I've ever seen. I've traveled quite a bit, been to many places. I love sunset and sunrise, but this was the best, which is you can actually see the island over there, which is very famous these days, the island of Tehran. Thank you so much, and now we're going to start the hands-on workshop. And we will, I think there are, volunteers. There are some excellent radiologists who will help us with each station. One will be for the vacuum-assisted device. One will be for core biopsy guns. One for wire localizations, putting a wire in. One for a clip deployment. And we'll have a couple of stations also for core biopsies. So we'll have more of that. So I would like to encourage everyone to go through all the stations, ask all the questions. I'll be walking around as well in each station and answering any questions, show you how I do it. And again, there are olives within these turkey breast or chicken breast. and you'll have to use an ultrasound probe, you localize for it. Localize it, you see your position, you put your needle, you assume that you're going to put lidocaine first, but you don't have to do that today. We're not going to waste a lot of lidocaine for chicken breast or turkey breast, but you have to do this for your patient. And then your sample, and you see your sample when you come out. We, I think, selected the olives, which has pickled carrots in the middle, so you actually can see what sample you got when you sample. Hopefully you get the green olive, the red carrot, and then the green olive again. That's a good sample. If you get only the green, then that's mean, except if you're intentionally doing the superior, middle, inferior, then you're probably going to get, parts of the green only in one of the samples. But that should be expected. So just broken down into stations. Please join each station. I think the numbers, we have 6 stations. So I really thank the organizers for arranging that. I've done this workshop before on 2 stations, and usually it's a bit more difficult. But now we have 6, so divide yourselves on 6 stations, and everyone should try everything before you leave. And hopefully, with that, the people who are doing it will get better at doing it. And the people who are not will hopefully start doing it and feel comfortable that they can, and they can even practice in their own facility on a turkey breast a couple of times, and then they can offer it to their patients, hopefully, inshallah. Thank you so much, and we'll see you at the stations.